Hi, everyone. Thank you for the invitation to speak here today. My name is Jay Patel, and I will be presenting this talk on behalf of Dr. Jayashree Kalpathy-Cramer, who is the current director of the QTIM lab at the Martino Center for Biomedical Imaging. Over the next 10 minutes, I will highlight some applications of ML and AI to neuroimaging. Before we begin, here are Dr. Kalpathy-Cramer's disclosures. First, I'd like to start off by identifying some of the members of our lab, in particular Ken Chang, Katerina Hobel, Mishka Gidwani, and myself. While we have many people who work with us on a host of different projects, the four of us really had a key role to play in the specific neuroimaging work I'm about to present. There are many different areas of research for AI and neuroimaging, and today I'll specifically touch on a couple of those areas related to segmentation, response assessment, and radiogenomics. GBM is a very aggressive tumor with dismal outcomes, as you all know. Imaging plays a key role in the diagnosis, treatment planning, and response assessment in GBMs. And thus, there's a lot of opportunity for sophisticated image analysis techniques that use these artificial intelligence techniques. When talking about segmentation in particular, the most popular approach is the UNet architecture, which is pictured here. UNets have been used to achieve state-of-the-art segmentation results and form the base for all the segmentation work that will be presented in the remainder of this talk. Many groups, including ours, have been working on developing good segmentation models for primary gliomas. Public datasets such as BRATS have really pushed this field forward. And as shown here, we're in a good place to automatically estimate tumor volumes. One challenge, though, is that we don't necessarily have good ways to predict which cases were segmented well and which should be reviewed / edited by a clinician, but a number of groups are developing such methods. In particular, we're actively working on ways to extract voxel-wise uncertainty information from these networks. Pictured here, we can see low-grade glioma patient with T1 pre, T1 post, T2, and FLAIR imaging. While this patient has a fairly well-defined region of edema, as seen on this FLAIR imaging, none of the four modalities show the tumor core component well. Thus, we expect there would be high amounts of inter-rater variability for tumor core segmentation and would like our model to indicate this in some way. Looking at the uncertainty, voxel-wise uncertainty that our model is outputting, we can see limited uncertainty for whole tumor, really only present along the borders, which is what we expect. And this implies good segmentation performance. Conversely, we note a large amount of uncertainty present for tumor core segmentation, clearly indicating the difficulty of the underlying task. In order to flag patients for manual review by clinicians, we need to convert these voxel-wise uncertainty metrics into subject-level metrics. Seen here, we plotted subject-level uncertainty against the dice score for the enhancing tumor, tumor core, and whole tumor components of the glioma. And we can see a fairly strong correlation present, where larger uncertainty is correlated with poorer dice score. Once we have a way of estimating the volumetric tumor burden, a logical next step is using this for response assessment. Here, of course, we'd like to assess if the patient has experienced a complete response, partial response, stable disease, or progression based on this criteria. To do this, the response assessment in neuro-oncology, or RANO criteria, is often used. The general idea is that the radiologist manually chooses what they believe is the largest diameter and cross diameter for up to 5 lesions. Of course, there are numerous confounding factors such as tumor shape, extent of necrosis, blood, imaging artifacts, etc., that reduce the amount of the inter-rater variability for this type of measurement. To show this, we had 2 clinicians perform RANO for us. Even though they both work very closely together, we can see only moderate agreement in the RANO criteria, indicating that the definition of measurable tumor was quite different, or at least difficult to assess. The obvious solution to this is what we call Autorano, which simply automates this task of generating the bidirectional measurements for you. Overall, the main takeaway from this slide is that both the automatic volume measurements and the Autorano are just as good, if not better, than the manual measurements we can perform when we assess inter-rater variability. I'd also like to say that a number of groups are working on deep learning approaches to predict molecular markers. Something we've done in the past is to predict IDH mutation status from the raw imaging. And we've shown that there are some imaging characteristics of IDH mutant, and we can capture that with the deep learning models with high classification performance, testing set AUC of 0.95. Switching gears a bit to brain metastases, this is an area where machine learning approaches have similar applications. For segmentation, there are slightly different challenges compared to segmentation of primary gliomas. For instance, some of the challenges we face are a large variability in shape, size, and location of the lesions. Micromets can easily be mistaken for small blood vessels. In addition, patients can have anywhere from 1 to upwards of 30 lesions. So how do we tackle these issues? In our lab, we focused on modifying the loss functions of our networks to better handle these small lesions, but there are numerous ways to handle this, including specific architectural modifications to the UNet. Moving on to stroke, we know that fast and accurate segmentation is imperative. For segmentation, even though we can once again use essentially the same techniques we applied to GBM and brain metastases, there's still challenges to overcome. Most significant is the quality of the imaging. DWI, which is used for detection and segmentation of strokes, tends to be very heterogeneous in image quality. And we found that extensive pre-processing of the images can really help improve the overall model performance and generalizability to new data sets. Finally, I'd like to talk about how best to get these algorithms into the clinic. Here is an example of infrastructure at MGB for algorithm deployment in radiology. And we're really working in this section right here, where we need to create a module that automatically chooses the proper series from the PAC system, applies the pre-processing to these images accordingly, runs those images through a model, and then adds those images, the results, back to the PAC system in a format that is readable by the software clinicians are likely to use. And there are plenty of challenges to model deployment, but the one I really want to highlight is model brittleness. Brittleness refers to models that have excellent performance on the data set it was trained on, but perform inexplicably poor when presented with new imaging. Here are examples of different types of heterogeneity that might be seen. Here we can see different prevalence of disease between institutions. Here we can see heterogeneity stemming from different population distribution, so different gender balances, race, age, etc. And here we can see heterogeneity stemming from different acquisition protocols. Any one of these types of heterogeneity can lead to model brittleness, and in most real-world cases, we expect to see all 3 types of heterogeneity. In our collaboration with ACR, we were fortunate to get access to data from the Demis trial, and you can see that the 3 scanner types are highly different intensity distributions. And what I want to show here is that when a model is trained on just one scanner, it performs very poorly on the other 2 scanner types. And the only time we see good model generalizability and performance is when it's trained on all images together. So in summary, artificial intelligence has great potential in neuroimaging. And while the majority of the work is focused on segmentation and classification, there are significant opportunities to find solutions to challenging technical problems, such as model uncertainty and model brittleness. With that, I'd like to acknowledge some of the grants that funded this research, as well as CCDS for providing computational resources to us. Thank you for listening.